discussion that we will be discussing several themes in terms of public health, related to public health, sometimes which are not talked in the general media or in the general population. And then at the end, we will have a question and answer, that is questions from you all. The chat will be open shortly. You can put your questions there. But in the interest of time, Dr. Amir Sapkota will compile your questions and we'll have that at the third phase. Okay, let's get started and jump right into our program. This is a 1 hour, 30-minute program. COVID-19 is a pandemic, meaning this new infection or disease, I'm emphasizing new, is occurring globally and not as outbreaks in certain regions. So we have to treat it as, it's occurring everywhere. This virus does not discriminate and does not recognize borders. And by now we all know about that. However, it still needs to be understood at a local and regional level to implement prevention and treatment strategies considering local issues. The goal of this Zoominar session is to help provide the scientific knowledge of COVID-19 from a public health perspective as of today, July 25th, 2021. I emphasize the date because it is an evolving pandemic. General public globally have some opinions, especially in social media, that science is not being truth in this pandemic, since new data are telling us how the pandemic is shaping. I think everyone should be very mindful that science is the art of finding the truth. When science changes its opinion, in this case, it is based on new data and that are emerging globally. It is not lying to you. It is learning more, and it is the duty of academicians to tell the truth as we learn. Thus, the panel that we have will be discussing the state of COVID-19 in the context of Nepal as we know today. So without taking too much of your time, let me get right into it and introduce our first panelist, Dr. Madhav Bhatta. Dr. Madhav Bhatta was trained as an infectious disease epidemiologist at the University of Alabama at Birmingham, where he obtained his PhD degree. Dr. Bhatta is a professor of epidemiology and global health at Kent State University in the United States. He also serves as the senior public health advisor for Back to Life, a Germany-based NGO working on health and development issues in rural Nepal. He has been following the COVID-19 pandemics in Nepal closely and has published multiple articles in the newspapers in Nepal. And he's been sharing his insights. So it is very timely that he will be sharing his insights and his experience and observations in the panel today. On the personal level, Dr. Bhatta grew up in Baitari, so he does represent West Nepal. Dr. Bhatta, the floor is yours. Dr. Madhav?
Hang on. All right, thank you. I was having trouble with unmuting myself. Well, thank you, Dr. Sandeep Shrestha. It's my pleasure to be here, part of this distinguished panel of guests from Nepal, colleagues from Nepal, as well as the United States, to talk about the state of the pandemic globally, as well as in Nepal. Before I move on to my presentation, I'm going to disclose or talk about any conflict of interest. I do not have any conflict of interest to disclose related to COVID-19, but in the past I have received a grant subcontract from a local mental health agencies that was funded by Janssen Scientific Affairs, which is a subsidiary of Johnson & Johnson, and Johnson & Johnson actually has a COVID-19 vaccine that there's no direct conflict of interest regardless. But again, thank you, NACA, for allowing me to talk about, be a panelist here. And again, I'm honored to be on panel with colleagues from Nepal. who will share on the ground situation in Nepal. So my talk is going to be more of a global situation, COVID-19 situation that will provide some background information while we discuss COVID-19 in Nepal, as well as hopefully it will spur some questions and commentary later in the discussion section. As Dr. Sadip Shrestha just said, COVID-19 is a global pandemic that's impacting the entire world. And it is a global pandemic because it is caused by a new virus, as he rightly pointed out, which has a zoonotic origin. That means it started in animals, then jumped into human beings, and a most likely candidates are bats. And although there's some speculation about other theories on the origin of SARS coronavirus 2, the causative agent, the preponderance of scientific evidence today suggests it is a zoonotic disease. And because it's a new disease, everybody in the world, 7.4 billion people, are susceptible to it. And it's a highly transmissible disease. It's an airborne transmission because it's an airborne transmission. And in the beginning of the pandemic, there was some, not enough data to see whether it was just a droplet transmission versus airborne transmission, and that actually led to some issues related to recommending masks, especially in the United States, and the country is still suffering from the fallout from some of the confusion or lack of data. And it is a pathogenic organism. That means it does cause disease, clinical disease. It's highly infectious, it transmits, but it also causes pathogens. It's pathogenic, it's a clinical disease, and it's virulent in terms of the severity of disease it causes. And to the point, it's fatal. Anywhere between 0.5%, 0.5 to 2% of people who are infected end up dying. And that may not seem like a lot of, high percentage proportion of people, but imagine if all 7.4 billion people in the world got infected, that could potentially kill 35 to 70 million people. So it is a global pandemic because, for the last 1 year, there have been a lot of misinformation about, it's not a bad enough disease. Okay. Right now, we're defining COVID based on the viral presence of virus in the body using molecular test, either looking for the genetic material or antigen test looking for the protein of the virus in the body. And that's how we're defining somebody has a COVID or not. The other type of test called antibody test, which actually looks at the history of somebody having the infection in the past, but that doesn't tell you if they're currently infected. It's the diagnostic test, either molecular or antigen test, that are going to be indicating whether you have a current infection or not. So that's how we are defining COVID, positive. If you're positive, then you have COVID, but the infection and the disease have a long manifestation, different manifestation from asymptomatic cases to mild cases to really severe cases where it requires hospitalizations, and eventually in some 0.5% or 2% people actually are dying. So, we have to really think about in terms of the impact it is going to have, both in terms of the public health impact as well as the clinical and health service impact. Understand what is the breakdown of the clinical cases versus asymptomatic cases or severe cases, because when asymptomatic cases are also transmitting the disease, the virus, then from a public health perspective, that is really important to know, and what percentage of people are doing that. From a clinical health service provision perspective, we want to know how many people are going to be severely infected and then potentially require medical treatment as well as the hospitalization. So it is an evolving pandemic, as Dr. Shrestha just alluded, both in terms of the virus is evolving, and the virus that started in China infected Europe, North America is different than the virus that is now the Delta variant that is now predominant in most of the world. The Delta variant that started in India and now is actually the predominant. And what the virus mutates because every time virus replicates, it potentially makes errors or changes in its genetic component. And if those changes are sufficient enough, gives it more competitive advantage in terms of the transmissibility or pathogenicity, then that is going to take overtake the existing strains. And that is important to know both from a epidemiologic perspective, because if it's more transmissible, then more people are gonna get infected. Even though it may not be pathogenic, it may change in the pathogenicity, but if it's more people are readily getting infected, then then you're going to have more people who are going to get sick, regardless of whether the pathogenicity or virulence of the virus changes or not. And if you look at how the epidemic has evolved, both in terms of the time and geography, it started in China, went to Europe, then into the United States and North America, and South Africa, South America. And at different point in time, different countries are going through different waves. Now the United States is going through a potentially fourth wave, versus Nepal is essentially waiting for a third wave. And if you look at the global distribution of cases and death, it has substantially changed. And it's not only just a function of virus, it's also a function of the interventions as well as the mitigation measures, and now the vaccine that has come in line. So the pandemic has had impact globally, every country, every society, both in terms of health, economic, and social impact. And just purely looking from the health impact, one of the way we can look at is one of the, I put it in quotes, as an easiest measure that you can look at is the mortality associated. I say it's easy because, it's not hard to, measure whether somebody's dead or alive. It's just, but the problem lies, is there a system where those deaths are accurately recorded or not? But so if you look at one of the indicators of the pandemic, just looking at right now, Europe, North America, and South America are actually the most impacted country on our per capita basis. United States, based on the official figure, has the highest number of deaths. But I say that official because whether the India and South Asia and Nepal, it's not as impacted as some other part of the world. Is it really that's the case, or is it a function of not having the accurate and valid data? So when we are assessing impact as well as comparing different populations in terms of the impact of the disease, we have to be careful about what is the state of the data collection and the information that is being collected. And the two examples I can give is, if you look at India, it has officially 400,000 deaths, but there's a new study that came about a week ago that suggests the actual deaths may be in millions, 1 to 4 million, depending on what matrix that you use. They are looking at what you call excess deaths. That is more than what you would normally expect, and using 3 methods, they are coming out with widely higher estimates. And Peru, in the last few weeks, they actually changed their estimate.
Madhav, we have 1 minute.
All right, thank you. Estimate from their mortality rate has actually upgraded to 200,000, and again, based on the excess death. So we do have several vaccines now available, and the vaccines are actually going to be the long-term solution. The question with vaccines, and we'll in the discussion section, we'll talk about different types of vaccines available if somebody have a questions on, but we actually have 7 vaccines that actually have the WHO has approved for emergency use authorizations. And the question, the issue, biggest issue right now with the vaccine is the availability of vaccine. Everybody wants the vaccine, but there are not enough vaccines in the world. And in most part of the world, availability is the issue. But in some parts of the world, it's now actually vaccine hesitancy, unfortunately. And that's the dichotomy you have in the world. we're in some parts of the world, vaccine availability is the major issue. In other parts of the world, there are enough vaccines, but not enough people taking the vaccines. So with that sort of a broad introduction, I'm going to stop right now, but we'll listen to the two other distinguished panelists from Nepal, and we'll circle back and look into the details of some of the issues that are going to be raised. And I'm going to provide some links to some of the writings that I've done in the last few weeks. And this presentation will be available with the different references that I have used in this talk. Thank you, Dr. Shrestha, and I move it back to you.
Thank you, Dr. Madhav. If you can take your screen out, and if Dr. Archana can upload her slides. So from the global perspective, defining, some of the keywords and key concepts of the pandemic as a whole, we'll move to Dr. Archana Shrestha. Disclosure, we're not related. Dr. Archana Shrestha is also trained in epidemiology, and she obtained her PhD from University of Washington. She's currently an associate professor in the Department of Public Health at Kathmandu University, School of Medical Sciences in Dhulikhel. She's also the Nepal director at the Institute for Implementation Science and Health in Kathmandu, Nepal. She also holds an adjunct professor in the Department of Chronic Diseases Epidemiology at Yale School of Public Health. Lately, for those of you in Nepal, you are probably familiar seeing her on TV and whatnot. She has been heavily involved in COVID-19, leading her own team at Kathmandu University, but also advising and consulting the government and Ministry of Health at various levels. Just to give some examples, she's a data advisor for the Epidemiology and Disease Control Division for COVID-19 response on Corona Crisis Management Center. She's the data audit lead investigator for Nepal Health Research Council. She will be providing some insights as a whole in Nepal, and also some of her and her team's work at Kathmandu University in 2 provinces. Dr. Archana, the floor is yours.
Thank you, Dr. Sadeep. Am I audible?
Yes.
Thank you for your wonderful presentation. Sorry, my introduction. So I will be talking about COVID-19 preparedness and response in Nepal over the past 1.5 years. Let me just quickly start with a quick disclosure that I have nothing to disclose and no any conflict of interest for this presentation. So let's start with a quick evolution of and development of COVID-19 and its response in Nepal. We had our first reported case on the 23rd of January 2020, and second case after 2 months after that on 23rd March 2020. In between that, Nepal Airlines aircraft airlifted about 175 Nepalese students from Wuhan, where there was a big epidemic of COVID, and then they quarantined in Kathmandu. Soon after at the time of second case, Nepal government also did all international borders were sealed. And soon after that, the next day, nationwide lockdown was imposed. It was a very, very strict lockdown. Despite that, we saw our first local transmission on 4th of April in Koilali district, and our first death on 14th May. It was unfortunately, it happened in Dhulikhel Hospital, and I was the one who did the case investigation for that. I was one of the team members. And then we have had some pause. We saw a very low case loads and less incidents. But soon after that, we started seeing increase in cases in Nepal. As a result, Nepal government announced a lockdown again. So sorry, the lockdown ended in 7th of July, and we saw our first wave. and vaccination started on 27th of January. Soon after that, we started seeing another surge of COVID-19, and our second lockdown started. It started with the Kathmandu Valley, but soon it extended to the whole nation. And we saw our second wave in spite of the strict lockdown. And after the cases started to go down, we saw the loosening up of the lockdown in June of 2021. This is a quick overview of COVID case trend in Nepal, and I'm showing it in comparison to India because a lot of us are very aware of what happened in India, and it was widely covered by international media as well. And I just wanted to highlight here that we had worse epidemic in India, in Nepal compared to India, both in the first wave as well as second wave. Our new cases per day per million population was higher in Nepal at the peak compared to India at the peak. Similarly, our death was also higher in Nepal compared to India. We can see blue curve showing India and red curve is showing Nepal. And at the peak, Nepal had actually more than twice the death rate compared to India. So we saw much worse epidemic in Nepal compared to India. Before the second lockdown, we also had a lot of things happening in Nepal after the cases went down in the first wave. We saw political rallies. We did not stop celebrating our wedding parties. We even enjoyed Machindranath Jatra. And soon after all of these breakage of social distancing policies and regulations, we started to seeing rise in cases, and it increased really rapidly. Within a few weeks, we reached to peak at this time, and then it is slowing down, but it is stuck over here. We are not seeing the expected decrease in our epidemic wave as we would see in the natural curve. It might be because we saw our peak during the lockdown, and now the lockdown has been loosened up, so people are mingling more, and there has been more breakage of social distancing policy, not much compliance in masking. That is why the number of cases is not decreasing down, and in the recent future it is expected or predicted to be increased a little bit. This is the province-wise vaccination status. Overall, Nepal government showed a really high commitment in vaccination to provide vaccination to all population in Nepal. However, it was not able to deliver in practice. We faced a lot of obstacles in between relating to access to vaccine. We could not even get the ones that the government actually purchased. So the vaccination rollout has been a little bit slow. And the overall vaccine coverage in Nepal is 4.5% of the population, and most of them are health workers, because health workers were placed at the first priority. If we look at the distribution of vaccine coverage by province, we see that there is a big disparity there as well. For example, Bagmati province has 11% coverage, and province 2 has only about 1% coverage. This graph is showing total number of reported cases per 100,000 population from the start to July 23rd, and the darker red means more cases per population was reported. So we see that the central Nepal had much more cases per population, per 1,000 population were reported, and in west, especially Bankhe and Surkhet were affected, and in the east, Morang and Sunsari were more affected. So this may not represent the real case scenario in Nepal, because it is only showing the number of, based on the number of reported cases, which is again determined by how much testing was happening where. So this table quickly gives us a scenario of testing, and we can clearly see that there was also a big disparity in how in the number of tests that were happening with respect to the population in the province. Clearly, Bagmati province had much more testing that was happening compared to other provinces, and province 2 was doing much worse. Meanwhile, all of these testing centers were actually centered in urban areas, and there was not much access to testing in rural areas. And this gives a glimpse of an example of what is really happening. So this was a press release from Gandaki province about a village in Barpak, a specific area in Barpak village, where they observe a lot of people reporting symptoms, COVID-like symptoms. And in merely 1 week, 10 deaths were reported in that specific area. And then they sent teams to investigate that and found that there was an epidemic in that area. And initially they could not detect it on time, or like before these dates were happening, or before there was havoc created, because clearly there was not access to testing in this part of Nepal. It was basically affected by 2 things. One was the testing centers were located in the urban areas, and second, because of the lockdown, people in rural areas could not go to these centers even if they had symptoms, or even they suspected themselves of having COVID-19. And then that is why local media also did a lot of coverage later, because these numbers were clearly not reflected in national reports, and we could only imagine or expect the extent of epidemic in the rural areas through these different anecdotes from newspapers. Similarly,
So now we have 2 minutes.
Okay, so we also had same issues with the treatment. Treatment coverage was also, there was also a lot of disparity in the treatment coverage. And Nepal government had this response network where federal government, provincial government, local government, universities, non-government organizations were working in their own areas and expertise. They were all trying to help, but clearly we could not see a really coherent or integrated COVID response within the nation. Meanwhile, KUSMS did some work. We started surveillance systems for COVID symptoms monitoring. We also partnered with ETCD and COVID Corona Crisis Management Centers in epidemiological analysis. We also conducted master's training for case investigation and contact tracing. We helped and National Health Education and Information Communication Center on epidemiological updates. We also helped build capacity of lab strengthening. We also did specifically partner with Karnali province for case investigation and contact tracing. Similarly, we also supported medical equipments through our different partners, like such as Direct Relief and AIDS Foundation. Dhulikhel Hospital offered 126 SDU and 100 ICU and provided COVID care. Regarding the variants, Nepal government announced that we have 2 variants circulating in Nepal. One is Alpha and Delta, and Delta variant has been a specific variant of concern because most of us are vaccinated. Those who are vaccinated have been vaccinated by AstraZeneca, and it has been said to be about 60% effective against Delta variant. So Nepal government has placed much more emphasis on these 2 kinds of variant in Nepal, and that has been the most challenging part in the years to come. In the interest of time, I'm just going to my last slide, just summarizing the lessons that I personally learned during this time. The first thing that we really realized that this is a special situation. This is not normal at all. And what was the most important for us was to get out of our comfort zone and really extend ourselves to help and support and participate in responding to COVID-19. And everybody is overwhelmed. Like be it a person, be it an organization, be it a government or non-government organization, hospitals, a small health center, everybody is overwhelmed. So we really need to be considerate of that while we are doing any COVID or non-COVID related work. Communication regularly with different partners was very important, and that's how we were able to secure funding and other support for our COVID work. We also worked a lot with different bilateral organization, government organization, and non-government organization, and that definitely caused synergy to our efforts. What I learned most was the perseverance during this time. We really, when we believe in something, it really helped when we were committed to that and just kept going, that we would. And then we also saw a lot of failure. Failure is inevitable. And that's how we accepted, and that's how we kept moving. And finally, the biggest challenge and the strength that I saw in Nepal in COVID response was the novice decentralized structure. We have so federal government, provincial government, and local government were working tirelessly, but on their own, and there was some disconnect between these in terms of chain of command, as well as how the constitution really authorized them to act also in this kind of pandemic situation. But at the same time, there was also a big strength in terms of how quickly local governance and how quickly the province government could act at the local level in order to, like, for example, managing the migrant workers that were coming into Nepal, and expanding the testing when there was no testing services available at all in Nepal, and even expanding the treatment when we saw a big insurge of COVID-19. So I'll stop here, and we look forward to your comments and questions.
Thank you, Dr. Arjuna. You touched on a lot of subjects, and we'll be talking about that in our discussion later on. So from Kathmandu, we'll go to East Nepal. Our panelist there is Dr. Paras Pokhrel. Dr. Paras Pokhrel has a medical degree, MD, in general physician and community medicine. He's currently professor and chief for the School of Public Health and Community Medicine at BP Koirala Institute of Health Sciences. He has served in many academic, provincial, and federal ministry committees. He also serves as a member of academic committee in India, Indian Institute of Public Health Foundation of India in New Delhi. He has also worked as regional technical advisor for the WHO. With his wealth of over 2 decades of experience in public health, he will be talking about the state of COVID in Province 1 and some of the great work that he and his institute has been leading. Dr. Pokhrel, the floor is yours.
Thank you.
Somehow your slide is not showing up properly. Dr. Paras, you there? Okay, I'm not sure what has happened, maybe technical issues. So once he joins back, we'll get him on. Maybe we can just start discussing a few things. Oh, maybe he's there. All right. Dr. Paras, go ahead.
I think you are muted, Dr. Paras. Go ahead and unmute yourself first.
Okay. Okay, so we'll start here. Namaskar to everybody.
Dr. Paras, could you make that slideshow? Yeah.
Yeah. it's okay for everybody. Am I audible to everybody?
Yep, you're good.
Yes.
Yeah. So namaskar. We'll start that as already discussed, and thank you for your kind introductions. I just, for the keeping in mind in our time, I'm talking about province number 1, and in province number 1 we have almost 1, 2, 3, 4, 5, many centers who is working for COVID-19 management at the moment, half government sector and half private. So mostly medical college and zonal hospital. This is just I'm focusing what BPKHS we are doing. That is just I'm copying what the everyday report is available in our institution web page. So this is nothing new to you, but just to show that what institute is doing. Basically, what we are talking is the vaccination status. I will not talk more. We can discuss later. But so far, we have just a 3% coverage, where Dr. Archana also mentioned how much, even within the country, differences between one province to other province. We were talking that, one of the good thing in this country, and I just noted there is a study from Nature that which country has highest number of people looking forward to take the vaccines, and Nepal stands first. So this is what Nepali people are looking for. There is no vaccine hesitancy so far. The only availability matters. Everybody is willing to have the vaccines. Maximum people are looking towards vaccines, but the access is the problem. That goes to province number 1 as well. Sorry. Now, what public health measures we are doing at province number 1? If someone is very familiar with the health system in Nepal, we have the Ministry of Health in provincial level, which looks after 2 disciplines. One is education, another is health, called Samajik Vikas Mantri. So they decides what to do in a provincial level. So now what they did is they are providing education materials where we have some say on it. They do the travel restrictions. Today only one of the town in Damak is completely closed, and they do the quarantine management, case investigation, contact tracing, and community level screening and testing. So what they do means what they did in the first wave, which may not be in the second wave. Remember one thing I always say, that what Ardhana presented is something very interesting. The anatomy of health system in Nepal is beautiful. What doesn't work is a physiology. The most of the time our documents are well laid down through many sources, and we copy, we are derived by the consultant. But what doesn't work in a grassroots level is that similarly it doesn't decentralize. Decentralized means most of the time is a delegation of work, not authority. So sometimes it doesn't work. What they are doing they did in the province number 1 in wave 1 is a very aggressive testing approach. The BP Koirala Institute of Health Sciences was the first outside Kathmandu Valley having PCR test, and that to be also not from the government sector we got any support. We have fortunately our own Kalazar research program where the PCR was already available in the institute and molecular lab was there. So we could do the test after the government granted the permission to us. So we were the first people to do test outside Kathmandu Valley. And then we took lead in the province number 1 to help to the Viratnagar and other places also to start the PCR test for the human resources. And they are opted from the Ministry of Health equipment. Now, the second wave we lost. The reason is we got confused. We were in a full belief that we are almost controlling the situations. No, our expert has any clue that how the second wave will go. This happens in the beginning, even in the first waves, because people compared with the SARS, which did not travel through Nepal, though there was a good connection between Hong Kong and Pokhara, Hong Kong and Dharan. We were expecting in 2002 the SARS will reach Nepal, but it never reached. Not a single case has been diagnosed. So this time we thought similarly in the first wave as well. And once there was a case, we got panic without preparations. And the second wave was not expected because the Indian case scenario was also a bottom, 30,000, even up to 17,000 in Indian scenario. So we also were very happy. And in the meantime, when the second wave started, number of infected people went up. The saddest part or the tragic part was death increased 163%, one of the highest in the world. And that was still we are not sure whether it is death due to the nature of the virus itself, where the oxygen management was the most difficult, or we have the facility which are unable to manage the cases. So it has to be, we have to look up after at least some sorts of analysis we have to do why this much higher rate of death compared to any normal situations where their death rate is so low. Our death rate is unusually very high. So there we were failed to predict and prepare. And then that goes to the province number 1 also. We have a COVID hospital, and the resurgence is number of deaths. We already talked, and then now we have 90% of people infected with second wave are, see how it is. Archana has shown nice graph, but the case went like this, and automatically people were relaxed, and then the second wave surged up. This is the reason we should talk about. This is the political mass gatherings and rally and all these things happening throughout Nepal. So who is responsible to educate our politician is the biggest challenge for this pandemic. Even today, whether the crux of the problem is understood by them or not is still a question. And we didn't have a proper way of risk communications, lack of evidence-based treatment guidelines. If you remember how these treatment guidelines is in a different country, different protocol, and then significantly, there are many COVID experts, but when it comes to the reality in the hospital, fortunately in the eastern region of Nepal, we have a very good critical care medicine experts in 3 places, in 3 medical colleges and 2 zonal hospitals where most of the cases are getting treatment at the moment. But in the beginning, there was not enough oxygen. So second wave is mostly targeted because of the oxygen inefficiency, managing oxygen to the hospital. Now, at the beginning of pandemic, if you look the holding sites and the quarantine centers in the country is every corner, every village development committee, they did it. The reason that they did is I am sure that there was a budget for it. So everybody was attracted to do some sorts of work in the provincial level, in a local government level. And then what happened in the second wave, there was no budget. So the whole concept of public health has been banished. Nobody is ready to start quarantine center. Nobody is ready to start with their isolation centers because everything was budget motivated. So we could not mobilize local governance and provincial government when the second wave started. And that doesn't differentiate even today. The situation is same. Mostly cases reach to the hospital when it is a very difficult to manage at home or local health institution. So most of the cases at BP Kerala Institute of Health Sciences or Virat Hospital or Kosi Zonal Hospital are referred cases, and that reaches in a very late stage, which is very difficult to manage. So this gap is still there. That may be the one reason where the hospital death, every day we face 2 or 3 deaths in the most of the hospital, which taking care. And then
Dr. Paras,
what
we have 2
happened?
minutes.
Yeah, most of the, I'll take a maximum 2 minutes. So what is the migration issues? Many people do not know what is the porous border India and Nepal means unless you stay in a border districts. Even you stay in the hilly districts or mountain districts, you may not understand what it means. Even today, closed. The moment is not closed. The official border is closed. There is a porous, another alternative side to commute in between the country. It's next to impossible to stop the border. And mostly this border issues is, I already discussed that 5 states, Bihar, Sikkim, Bengal, Uttarakhand, and Uttar Pradesh. These 5 states is responsible, and health and education is a state's matter in India. So even talking with Delhi, this is not going to solve. One of the photographs is provided by some of my friends, which was the India-Nepal border situation. How in the quarantine you can hold people like this? So people didn't stay in the quarantine, they ran away. This was the reason. And when you have started in Khari party from China, you have a 5-star treatment. When it comes to the workers level, you don't pay attention. So that was a big difference between the people which you treat from coming from abroad. Now I just want to show you a little bit about BPKHS, where we have some hospital which treating around 100 patients now at the moment admitted in this hospital. We just turned a rehabilitation center to the COVID hospital over 3 months. And for last 1.5 years, this hospital is running smoothly. There was some issue in between, but that has been settled now. Vaccination program we have started for healthcare workers with the country first time in the eastern region of Nepal, because they wanted to see the vaccines effect at BPKHS, and they took in other centers. Where we failed is just I'm putting the 2-3 point is very important. We have a very limited RT-PCR test kits, and still we are not doing enough investigations. Failure of leadership, we can talk a lot, but which leadership? All levels, academic leadership, ministry, and the political leadership. All we have almost at the same weightage to blame. And now I'll stop here, and we'll be happy to answer some of your questions. Thank you very much.
Thank you, Dr. Paras. That was very insightful. Some of the things that we were planning to discuss, you also covered it. So the next phase is we're going to go to a thematic discussion. For the audience, if you have any questions, please put it on the chat. Dr. Amir Sapkota will be moderating your questions in a little bit in the third phase. So one of the major issues in public health, is disparity in screening and vaccination. We all hear that catchy, phrase, nobody's safe unless everyone is safe. But still there is disparity. Like Dr. Paras said, maybe hesitancy is not a problem in Nepal, but delivery and availability of testing or vaccination is. So, but in Nepal, there is along with all the other factors, we have a caste system that is embedded in our culture, in our social structure, that also brings another layer of disparity. So I will start with you, Dr. Archana, because you covered a little bit on disparity. Can you comment on disparity in screening and vaccination in Nepal as of today? And what might be good strategies that has been taken in Nepal or lack thereof, and what can be done going forward?
Thank you so much, Dr. Sadeep. I think that even in my personal and professional life, I have never witnessed disparity so closely and so in front of my eyes, like how things are happening in Nepal and also in the worldwide, especially in terms of how we are responding to COVID, not just the vaccine, but also like COVID treatment, COVID screening, and how we are reaching out to the population, how we are communicating the risk to the population. Even just the availability of the mask is a huge issue of disparity over here. But coming back to vaccine, the access is a big problem, as we can see that Bagmati province, and there is no brainer why it is better access. There is a central and federal government over here, more urban areas, even the municipality level, the local community is much more empowered compared to other historically backwarded communities in other parts of the world. Specifically in vaccine, right now, the biggest challenge is even to just get the register. So Nepal government has just announced that you need to register online to get the vaccine. So this strategy itself is expected to create a huge disparity, because what percent of people in urban areas would be able to register themselves online, and what percent in the rural, what percent of the educated people would be able to register themselves, and what percent of uneducated, even like what percent of the people in like high socioeconomic status who have access to internet and computer and other things, compared to those who don't have access. So even starting with who willingness to get the vaccine is of a great concern here. And getting the vaccines, then of course the vaccination center are located in the feasible areas where more access, not accessible to everyone in this country. 70% of the people do not have like access to any kind of health center within 30 minutes of their distance, specifically in mountain areas, in hill areas. So even within, so there is a huge disparity. Like within the country, we see disparity among province. Within province, we see disparity among districts. Within district, we're seeing disparity among municipalities. Within municipality, there is a disparity among wards. Within wards, there is a disparity among like concentrated areas and non-concentrated, like rural and urban areas. So yeah, it's been a big issue. So I think just to touch upon like what could be a solution, I don't think there is a concrete solution to that, and it should be a continuous discussion over it. But Nepal has been really good in the vaccination program, starting from micro planning of vaccination from each and every corner of our country. We have run the vaccination program through primary healthcare outreach clinics, through our village health workers, and reached every nook and corner of the country. So I think activating that network right now is the most important. And how we are prioritizing our citizens is also important. Also, there has been a lot of anecdotals about getting the vaccines through payment to from different sectors. It's been an ongoing rumor, like, but how the government or non-government sector, or we as a citizen, really validate this information and act against it. And really, like, government, how can government improve the access? How can government bring more vaccine to the country? Right now, we are relying on donations. So we hear and then we see a lot of announcements about this many vaccines has been donated from these countries, and we are like going after a lot of non-government organizations, other government bodies, but we are not talking about purchasing vaccines ourselves. And even that, I think, and then if you look at the budget of Nepal, like millions of dollars have been committed to build oxygen plants in few centers, but why cannot we talk about purchasing the vaccine that's enough for our country?
Okay, thank you, Dr. Archana. Dr. Paras, you touched a little bit on migrant workers and the borders. Can you comment a little bit more in terms of disparity and whatnot in that population or other population that you see? Dr. Paras, you are muted.
Muted. Okay. So I was talking about, one of the biggest challenges we have seen this pandemic is migrant people in any developing country, India, Nepal, Bangladesh, Sri Lanka, same. What happened to the in-country migration, out-country migration? Some of the migrant people working abroad, coming home was a problem, staying place was a problem, and same happened in the border area. When they came, we are not able to screen, quarantine, isolate, test, treat them. The reason was they are from poor strata of the society. They are neither insured, nor there is a possibility to take care of their food, shelter. So this is the biggest challenge we faced and the whole world faced in this pandemic. So now how one can manage that? There should be a mechanism to address this in a public health. Migration and health became an issue. We have other problem, like if you have noted, our migrants were only yesterday, it is a big sad part in Nepal, the 24 or 25 people died in Malaysia and 23 dead body came yesterday in Nepal. That was a huge issue. I mean, some of them, whether it was COVID, non-COVID, that is already there. But this COVID aided this, fueled that problem. And now I'm staying in the eastern part of Nepal. We have border like Kakarbitta, Viratnagar, and Nirmali, which is in border province number 2. And then the influx of the people, not from only India or Nepal, there is even some of the people now you see from Bangladesh. You cannot distinguish. There are so many things is happening in these border areas who are working in that part of the country, and this how we can address this issue is a new thing, new phenomena for migrant workers. Now, testing, antigen test would have been better for the migrant worker, which we did not start in the beginning. And there is another player in this. If you look, misery to few is a festival, misery to many, festival for few. This COVID has proved again and again. What happened? The player came in is those private sector. They are not doing charity. There are many hospitals came up for the cost of public health. Government is unable to produce quality service in the hospital, so they sold their whatever they have, and they are getting treatment in the private hospital, where the disease itself is very unpredictable, so the outcome may be good or may not be good in any hospital. So these are the things which a migrant worker need to be addressed a different way. That is what I say, Sandeep, for now. Thank you very much.
Thank you. So we're talking about equity, equality, disparity. Dr. Madhav, question for you is, even among those who are vaccinated, we are seeing these breakthrough cases, and that has been a concern for the public. Can you, describe, breakthrough cases and vaccine effectiveness a little bit so the public is a little bit clear?
Sure, thank you. Thank you for that question. In fact, that's one of my pet peeves, even in the United States. Every day is on the news, oh, there's, so-and-so politician became, had a breakthrough cases. And my response to that is nobody said vaccines are 95% effective, 100% effective. These vaccines, COVID-19 vaccines, do not provide what you call a sterilizing immunity. That means if you get a vaccine, and if you get infected, the vaccine may not be able to clear or keep the viral load to such a low level that A, they're not going to show up if you test, or B, you'll still be maybe able to transmit to somebody else. But the first thing is no vaccine, the COVID vaccines are not 100% effective in terms of preventing the infection. There's a difference between infection versus a disease, but they are really, 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 really good. 90, 95, and 98 in terms of reducing the severity of the disease as well as the death, and that's what we want. So I think rather than saying, well, they're breakthrough cases, the thing way to look at it, oh, they prevent 95% of the deaths or 98% of the deaths or severe diseases. So that takes over, and that, why is that important? It takes into the vaccine misconception. And what people say is, well, somebody got vaccinated and they got infected, and why should I get the vaccine? Well, so that's one thing. The other thing, that these PCR tests are so sensitive, right? They're gonna pick up small amount of viral particles, and they may be test positive, but that they may not actually have sufficient viral load to actually infect somebody else. So those are the distinctions that need to be made, and publics need to be aware of those so it doesn't create false or misinformation regarding the efficacy of or effectiveness of the vaccines.
Thank you very much for clarifying that. In the interest of time, we'll have one more question that will go around. So one of the things is, we have been focusing so much, this is everywhere, we have been focusing so much on COVID in the past, 18 months to 2 years or so. But Nepal relies heavily on public health programs, whether they are run by the government, NGOs, INGOs, or institutes. I wanted to see, how these, programs have been impacted, given that so much, focus has been given to COVID. I'll start with you, Dr. Paras.
Yes, it touches everyone's life. Those who heard about William Osler's aphorism that if you learn tuberculosis, you will learn medicine. Today, if you would have been, you would have said, if you learn COVID, you will learn the medicine. So this is the changes occurred in 50 years' time about medicine. It touches everybody's life. And what we were unable to do is the non-communicable disease became all of a sudden a challenge to manage in COVID. Because if you look the mortality, mostly it is caused by either hypertension, diabetes, and cancers, where there is mostly cases has fatal outcome. So at the same time, we closed everything. Hospital was not functioning well. And our public health workforce is not trained as such. If you look, the colleague who are working in North America, you might be familiar that we do not practice public health. We practice population health. We do not have the genomic surveillance. If you ask our public health professionals working in the government system, many of them, they may not understand that. Nobody has knowledge about molecular biology. So we didn't prepare the public health workforce to work in that, which came all of a sudden a new challenge like COVID. Would have been anything like variant. Like if I give example with the Indian colleague that Maharashtra has National Institute of Virology, the premier institute in Pune. They produce the vaccine in Pune, and they produce Delta also in Maharashtra. So this is the failure of public health. They could not detect early. They could not do the genomic surveillance early to identify the Delta and control within that territory. So this is the challenge lies ahead for us to change the total orientation of public health towards more of a infectious disease, and that also related to biomarkers. The first thing, we have to change our public health workforce orientation. Second, what you said is the challenge of COVID has neglected two areas. One is a maternal health, and the second is the non-communicable disease in this country. The mothers, again, the maternal death is increasing because the hesitancy to deliver in the hospital. And hospital became the hot spot to transmit the disease. The reason someone started, for 6 months, nobody accepted that it is airborne disease. Even WHO has totally confused and chaos. So the hospital design in our country is not like, you see, any procedural room in this country in a hospital is a center of infections. Go to the ENT, go to the eye department, most of the, go to the microbiology lab. In our hospital now, who are mostly infected? It is the people working in the procedural room. There is no cross ventilation. Hospital is designed as such, and the air condition is there. So these are the challenges we will be going to face in the future, Sadeep. Thank you.
Thank you very much. So you touched a very important one on, mother-child, maternal health. Dr. Archana, there is another, pandemic that a lot of people in Nepal don't want to discuss about, and that is mental health. How has mental health been affected by COVID-19? Sorry, your mic is not working.
Am I audible now?
Yes.
Okay. Yes. So, yeah, mental health has always, not just during the COVID, but it has always been a neglected issue in Nepal. When we started COVID, when the COVID-19 started to hit Nepal, we started with a strict lockdown, even when there was no COVID, not much COVID. And then we kind of, as a population, we faced a lot of fear, anxiety, and loneliness during that time. It was very, very strict at that time, especially in the urban areas where people are used to living in a lot of crowd. So there has been some publications from Nepal that has also highlighted increased prevalence of COVID-19 supposedly affected by the COVID-19 related isolation and lack of social interaction. There were some like anecdotes reports about the increased rates of suicides in Nepal during that time. And there was a lot of concern about the COVID-19 patients themselves and their family members. There had been a lot of fears and stigma and discrimination around that. Those who had been, especially in the villages, those who came from foreign countries, and in our context, mostly from India, they were not allowed to enter in their village. Like, they had to hide themselves even when they were in their house. And a lot of people were hiding their COVID status as well. Even in our university, we faced that a lot of students were not allowed to come back to the university when they were from Tarai region. I personally faced one issue where I had to go and counsel one of the house owners to let the student come back to the house because the classes were resuming. And I think that has had a lot of impact on not just the COVID-19 patients who were facing the discrimination, but also their family members, and even the neighbors were having a lot of fears. Initially, when COVID was detected, a lot of people used to go to the COVID-19 patient's house, and there used to be like a big sign that, okay, this is the house of COVID-19 patient, and people would also be afraid to even like cross that specific path. So mostly first wave was driven like mental health. I think the mental health status were strained by this kind of stigma, discrimination, loneliness, fear, anxiety, imposed by the new disease. And I think it was also very much attributed by the lack of knowledge about the disease. Even when we were designing the isolation center in our hospital, even clinicians were very afraid that it was an airborne disease. So there was a lot of confusion in the beginning as well. But as time passed, people became much more relaxed. And now I think it's opposite. They don't care about COVID much. They are loosening up. They are like not taking care of public health measures like distancing, sanitizing, mask using, use of mask, and even like proper use of mask is really poor. And people are getting COVID. In our own one of our own research, we found that the people who had COVID-like symptoms had increased higher rates of depression, anxiety, and stress compared to those who did not, even within the COVID-19 patients who did not have COVID, we did not have symptoms.
Okay, Dr.
And
Arjuna, I think
yeah.
we have some questions. I didn't mean to cut you, but I think that this can be linked to the other questions that some of the audience have. So I'm going to transition to Dr. Amir Sapkota. Before I transition, one of the things that Dr. Sapkota is an expert is in climate change. So I was wondering, Dr. Sapkota, if you could also say a few words about how climate change has impacted a pandemic like this, or if we've learned anything, and then go to the questions from the audience. Thank you.
Thank you, Dr. Shrestha. I think it's certainly a very impressive panel here. And in the context of climate change, I guess at least there is no evidence thus far that directly links climate change to the ongoing COVID crisis. But what is important to realize is when we talk about climate change, we're often talking about the increases in frequency of extreme events like extreme heat, extreme precipitation, ongoing heat waves. And then there's this notion of compound hazard, which applies to a situation where there are multiple hazards come into interplay and interact, and the combined effect of those hazards are much worse than if they were present in of themselves, right? So in the context of COVID-19, so we know the hospitals are overwhelmed right now treating this COVID patient, right? So when you have, for example, heat waves or other diseases that are driven by climate change, so we don't have enough resources to focus on those, and so you have a lot of people dying of cardiovascular or the cardiopulmonary health outcomes because the resources are sucked up by COVID-19, and that particularly applies, gets magnified in a lower resources setting. But what I do want to, before starting with the audience's question, I do have one particular question that I want to pose to our distinguished panelists, and that is this notion of reactive versus proactive approaches to pandemics, right? So thus far, we are just reacting to it, but this has shown that this approach is not enough, right? We need to be proactive. We need to be able to anticipate these hazards and prepare for it, so we don't have this kind of calamity in our hand. So in that context, I want to pose a question particularly to Dr. Paras and Dr. Archana. What do you see, how can Nepal move forward in the context of preparedness? Both, I'm talking about both the medical institution, the public health institution, the economic institution, as well as the political institution. What are the lessons that can be applied in terms of, changing things, so we can, as a country, as a society, can be better prepared for next pandemic that may be in the horizon 5 years from now or 20 years from now, whatever that may be? Dr. Archana or Dr. Paras, whoever want to take a stab on that first.
You're muted, Dr. Paras.
Host unmuted you, yeah. Thank you, Amira. I think this is the million-dollar questions, not to Nepali diaspora, but to all of us. How we can be proactive to the planetary health, and that to the next pandemic or any of these sorts of. Recently, if you remember that Sindhupalchok landslide was an example that if that happens and within the pandemic, how we will be able to manage that type of episodes. One of the advantages which we are on the process is we have local governance and provincial governance in anatomy. If it translates in functions, if it translates in physiology, I'm sure that will be a big strength, because the local governance has to be prepared to the challenges, and we have 708 local governance in the country, and that local governance has to be equipped with the human resources, infrastructures, and knowledge and skills. That is one. The second is what the public health workforce, public health practitioners and public health academia can do together. Is we have to find a way that the people can perceive us that we are not fortune tellers, The COVID may make most of the public health professional as a fortune teller. They say something today, and if you find in Nepal in the morning in radio, every public health professional talks in a different languages, different expectations, different predictions. That infodemic is not created by layman, that is created by educated lot. That has to be changed, country like ours. The
Thank
third
you,
important
Park.
yeah.
So in the interest of time, Arsana, do you have a few words to add to that?
Sure, sure. I would just want to add, I agree with Dr. Paras, and in addition to that, I think our nation really has to prepare on really how we can identify that it's coming. So we are really lacking in how we manage our data, how we're collecting the data on this. So a lot of things, why we are being so reactive in this situation is a lot has to do because we do not get the proper right kind of information at the right time, and we are reacting after we see a huge wave coming to us, and we don't see the small wave that's getting larger. So one of the things that would be is to establish a comprehensive surveillance system that's data driven. I think another thing that I would like to highlight on and add on to Dr. Paras would be the denial that we as a professional and as leaders, the kind of denial that I have seen is pretty high, and that has to be crossed over with the right kind of dialoguing. So I think we also need to open up a platform in our country, in the ministries and in local governance, to facilitate that kind of dialogues between those who are making the decisions and those who have a right information, and then how we can strategize to work together to prepare.
All right, thank you very much. And I think this whole the notion of conflicting information coming, it's very it's very challenging, and that reflects the evolving nature of the virus and the science itself that Sadibji alluded to earlier. So getting to the questions from the audience, I think the first question from Professor Brijesh Thapa is similar to the one raised by Biswas Koirala, and which has to do, which deals with this, vaccine, right? So some people have received vaccine months ago and haven't received first dose months ago, and they have not managed to get the second dose. In other instances, those people who got the vaccine a while ago are now thinking about getting a different doses, made by different manufacturer. So there's this, confusion about what happens if you are to mix and match those, vaccines made by different manufacturers. So I was wondering if you could comment something about that. This applies to all three panelists, I guess. So I see Madhavji has started to take a stab on it. So do you want to start, Madhav?
Sure, thank you for that question. Yes, the dosing interval, there are two issues that are raised. One is, why aren't people getting 2 doses when they are recommended? And that's a logistic questions, or more of a management question. From a biological perspective, I think what we know is if the interval is increased, let's say you need to take a dose within 3 weeks, but you didn't get access, you got 5 or 6 weeks later, I think that still be effective and helpful from a biological, immunological perspective. The second question is, why didn't the people who got the first dose didn't get the second dose? That's a management issues that probably maybe the people on the ground can answer that question better. And the other is mixing different types of vaccine. As of right now, they're not recommended. And especially, I think in my presentation, I alluded, not all vaccines are the same. The technology we have right now, 3 types of vaccines that are approved: the mRNA vaccines, they're the viral vector vaccines, and the whole cell vaccines. In Nepal, the Johnson & Johnson is a viral vector vaccine, and similar to AstraZeneca. And then the Chinese vaccine, Verocell, is a wholesale vaccine. So you certainly don't want to mix the different types of vaccines, and even made by same different companies right now is not indicated.
Anything to add to that, Parasji? Okay.
Yes, thank you. I think that is a logistic issue, and Covishield is a question maybe intended to the Covishield, which is 1 million people are waiting for a second dose because it was almost ready to, almost paid for the buying with India, but because of the insurgency in India, they could not export. But Amir and Sadeep raised that it is an evolving science, and every day we are learning that Covishield has a much better performance if you have wider gap. So I'm sure within 2 weeks we will have a vaccines of 1.6 million, and those people who have already taken 1 million vaccine will be going to get second jab. So I'm sure that problem will be solved. That is one thing. And the second thing is not a very good report from Israel that even the mRNA vaccines is waning off for the older populations, and so the booster dose is needed. And so the Israeli study shows that even the vaccine is not permanently having solution unless there will be booster dose or something else. So we have to go through the evolving science and collect the best evidences. Now the Covishield's first dose was also partially protective, but the second dose, once there will be, even they say the delta, also severity of deltas will be less. So I hope that with the 1.6 million doses reaching within a week or 10 days in Nepal, that problem will be solved. But it is a logistic problem.
Thank you. And one last question that we have, I think there are several other questions and we're not going to have time to get through it, but one question is raised by Swatantara Gautam, and he's wondering the implication of waiting in line to get COVID vaccine from 2 a.m. in the morning. What are the danger of getting infected just by virtue of standing on that crowded line? Could you comment on that, Archana?
Of course, that has been a lot. There has been a lot of concern about that, and there is not much research evidence, but we do know that the crowding increases the risk of COVID transmission of COVID-19. So that certainly is a possibility, and it's not just the line. So a lot of centers are giving away the tokens, and when you collect the tokens, people are not even standing in the line. They are like really crowded, desperate to get the tokens when it is started to distribute. So actually in practice, it's they are in line until the token is announced, and once the token is announced, then everybody is in the same room, like, trying to get it. And there definitely is a lot of risk around that. Right. So to address that, government is trying to prepare a list of pre-prepare a list of people who are willing to take the vaccine, register them online, and that has its own implications in terms of disparity as well.
Thank you. I think that was a great conclusion to our discussion. So I want to take the last couple of minutes to wrap and recap what we learned. But first and foremost, I do want to take this opportunity to acknowledge NACA for bringing us all of us together. This was a fantastic Zoominar, should I say. And please remember, NACA is a completely run by volunteers. So it requires a lot of effort on these volunteers, and there's a lot of work that goes behind the scenes. So I want to extend my heartfelt gratitude to the executive members of NACA, including Milanji and Ganji and all others who have made this possible. So just to recap, I want to start with Sadeepji's comment earlier that this pandemic is obviously global and it does not recognize any national boundary that are created by humans, right? So collective effort on this obviously makes a huge difference. And the other is that the virus is constantly evolving, and so is our understanding of the virus itself. And this is, I think, reflective of the science. Science is not static, right? It's constantly evolving. But the challenge in this case is the evolution is happening so fast. It's literally happening in lightning speed, right? And each new things that we learn that has an implication on our real life that unfold on real time, whether that be our freedom of movement, whether to wear mask or not to wear mask, development of vaccine, and obviously the treatment of patients in the hospital, right? So that is what is so different in this round is these changes are happening so fast. And because of that, there are a lot of uncertainties, right? And we as a scientific community, I felt as though have not done as good of a job in terms of conveying that uncertainty and conveying that evolving nature of science. But I do want to I do want to bring your attention to one last point, and that is, like Madhavji said earlier, the infection fatality rate in this case is 0.7%. In that, if you get infected, 0.7% of the population die. But I want to bring your attention to another virus, which is the Ebola virus that was first discovered in Democratic Republic of Congo back in 1976, which used to be called Zaire back then. That Ebola virus, depending upon the strain, has a case fatality rate ranging from 25% to 90%, right? Anywhere from 25% to 95% of people who contact Ebola end up dying. The average is 50%. So, think about the next pandemic. If the next virus pandemic has the case fatality rate that resembles the Ebola virus, but has infectivity that's similar to COVID. COVID is highly efficient in terms of transmission, right? So if we have that, you are talking about, instead of having 193 million people infected, and out of that 4 million death, you will end up anywhere, hundreds of millions of people dead just by, just using the number of people that have been infected so far, right? So I know this sounds like a, hypothetical scenario, but none of us thought about, a pandemic like this could be possible even 2 years ago. And the fact that each of these different strains of virus are here, with the COVID highly infective, in Ebola highly, very high fatality rate. Who's to say that the next pandemic is not going to have a combination of those characteristics? And those are the things I think the people in public health, we worry about, and same thing goes on the medical field too. So that's where I was getting to when I asked my earlier question about preparedness for the next, epidemic on the horizon. So this was a fantastic, Zoominar overall. I learned a lot, and I want to extend my heartfelt gratitude to NACA for organizing that. And I know we are running a couple of minutes over time in this, so I want to, ask my co-moderator, Dr. Sandeep Shrestha, as well as NACA host for the last comment, if they have.
I have none. Thank you all for joining. Hopefully, I learned as much as, and you all learned as much as I did. Back to NACA, Dr. Gyan.
Gyanji or Milanji, if you have any last parting words.